Okay. Dr. Megha Gulati, she will be presenting about ARN.
Yeah. Good morning all. So today my topic of discussion will be acute retinal necrosis. I will be discussing this topic with the help of few clinical pearls. Now I don't have any financial disclosures. Acute retinal necrosis, to start with, the American Uveitis Society has laid down the diagnostic criteria for acute retinal necrosis, which includes 5 essential and 3 supportive criteria. 5 essential criteria are: 1 or more foci of retinal necrosis in the peripheral retina with well-defined margins. There will be rapid progression in absence of antiviral therapy. There will be a circumferential spread. There will be occlusive vasculopathy with arterial involvement and a prominent inflammatory reaction in the vitreous or anterior chamber. These are the 5 essential criteria which are there. The 3 supportive criteria are scleritis, pain, and optic neuropathy or pallor. Now we discussed that the retinitis will be in the periphery. Does posterior pole involvement happens in acute retinal necrosis? It is very rare. So why so the periphery is involved? The short ciliary nerves, they penetrate near the optic disc and they travel anteriorly in the grooves on the internal surface of the sclera. So because these short ciliary nerves, the virus migrate through, the periphery of the retina is involved and the posterior pole involvement is very rare in acute retinal necrosis. As it is caused by the viruses, as the name suggests, the most common virus being the varicella zoster virus, followed by herpes simplex virus 1 and herpes simplex virus 2. Rarely, Epstein-Barr virus and cytomegalovirus has also been associated with acute retinal necrosis. Now, these are the 5 viruses. There are few case reports that non-viral cause of acute retinal necrosis is Toxoplasma gondii. So, that should also be kept in mind. Now, age and associated comorbidities helps us in differentiating the clinico-etiological differentiation in ARN. So, varicella zoster virus and HSV1, it is usually the likely cause when the age of patient is more than 25 years of age. When patient is younger, less than 25 years of age, HSV2 is the likely cause. Whenever patient presents with chickenpox or shingles on systemic examination, varicella zoster virus should be kept in mind. If there is history of meningitis or encephalitis in the recent past, or there are evidence of herpes simplex keratitis healed or active, HSV1 should be the likely cause. If there is history of maternal or neonatal herpes infection, or if the acute retinal necrosis is occurring adjacent to a pigmented scar, then HSV2 should be kept in mind. Why we want to differentiate the cause, we will see in the further slides, because management differs depending upon the causative agent. Now, starting from the anterior segment, we will proceed to the posterior segment, the findings in acute retinal necrosis. Now, acute retinal necrosis can also present with scleritis. So, scleritis in acute retinal necrosis will be likely diffuse rather than nodular. And it is one of the rare type of infective scleritis which will never present with a pus point. So usually infective scleritis have a pus point. Acute retinal necrosis, the scleritis or the viral scleritis will never have a pus point. On the contrary, the bacterial scleritis can be nodular or diffuse and they usually have a pus point. Now because of the scleritis or the scleral involvement, the sclera could be anterior scleral involvement or the posterior scleral involvement, the ARN, it is a rare type of retinitis that will present with pain. So any patient you are seeing has a retinitis and also has a pain. That is likely acute retinal necrosis. From sclera, let's move to the anterior segment. So viral anterior uveitis, as we know, is non-granulomatous. It is not like so. It can be granulomatous also. So viral anterior uveitis can be granulomatous or non-granulomatous. So whenever we see pigmented keratic precipitates, raised intraocular pressure because of trabeculitis, we make a diagnosis of viral anterior uveitis. Please dilate patient in such a scenario because these patients might have retinitis also in the posterior segment. So just it's a viral anterior uveitis, we'll not see the fundus, we'll see fundus on the next visit. It is not like that. Patient might also have acute retinal necrosis in such cases. Now from anterior segment, let's move to the posterior segment, the vitreous. Now vitritis in ARN can vary from mild to severe, and the grade of vitritis is directly proportional to the amount of the retina involved. Why is it important? More is the vitritis, more are the chances of retinal detachment in such patients. Now significance of area of retina involved. So more the area of the retina involves, poor the visual prognosis and higher the chances of retinal detachment. So it aids in guide for treatment and helps in prognosticating the case. Now, there is a clue in the retinitis itself in acute retinal necrosis. There will be a central clearing in this retinitis. So why the central clearing happens? It is because of the retinal cell death in the center, which is replaced by atrophic retina. And this classical central clearing is seen in viral retinitis. As I told you in the clinico-etiological differentiation about HSV2 that there will be history of maternal or neonatal herpes infection, or there might be pigmented scars. So, as we know, retinitis occurring adjacent to pigmented scar is classically seen in toxoplasma. But HSV2 is one of the differentials because reports are there that HSV2 can cause bilateral hyperpigmented chorioretinal scars, irrespective of the location of the retina. Although toxoplasma is usually at the posterior pole, HSV2 can happen at the posterior or in the periphery, likely in the periphery. So, retinitis occurring adjacent to the pigmented scar and with a central clearing. Think of acute retinal necrosis secondary to HSV2. Retinal hemorrhages are classically seen in CMV retinitis. It is not a prominent feature in acute retinal necrosis. Few hemorrhages can be seen at the margin of the lesion or perivascular. There is occlusive vasculopathy in these patients and it progresses beyond the area of retinitis and it indicates early optic nerve involvement. Because of this vasculitis, patient can present with central retinal artery occlusion in such cases, and inflammatory central retinal artery occlusion, ARN, should be a differential diagnosis amongst these cases. In although the immunocompromised or immunocompetent status does not make a difference in making a diagnosis of acute retinal necrosis, but in immunocompromised patients, the ARN, it is bilateral, severe, and a poor visual prognosis is associated, and more likely HSV resistance to acyclovir is there in these patients. So the viruses are there at the retina and the retinal pigment epithelium, but not in the choroid and the optic nerve and the vessels, the endothelium of the vessels. So at the endothelium of the vessels and optic nerve, they are mainly inflammatory cells. So it is not just the antiviral, we also need to treat the patient with steroids. So the acyclovir is the main treatment for ARN, but acyclovir is not done only for treating the primary involved eye, it is also to prevent the involvement of the contralateral eye, because the patients who were not treated with acyclovir, there are 5 times more chances of progression to the other eye or the involvement of the other eye. Now, valacivir is the primary modality and not the IV acyclovir, as we know. For how long should we give that? So the lesion usually resolves in 1 to 2 weeks in the involved eye, but still we continue the treatment at least for 2 months following resolution of retinitis in the involved eye, because the other eye gets involved in almost 14 weeks. So minimum 2 weeks after resolution of retinitis, the valacivir should be continued. Now, intravitreal antivirals, we don't have foscarnet in India. Ganciclovir is given 2 times weekly, and there are few indications when it need to be given: when the retinitis is more than 25%, when there is presence of occlusive vasculitis involving the posterior pole, and there is presence of serous retinal detachment. Oral steroids, as I told you, need to be started when retinitis is more, there is serous retinal detachment, there is more vitritis, and there is occlusive vasculitis. But a very important point, don't start oral steroids without antivirals. Oral steroids always need to be given under the cover of antivirals. IVMP is given when you are suspecting optic neuropathy in patients of acute retinal necrosis. So sudden vision loss in a patient you are following up with the acute retinal necrosis, in the first month it is optic neuropathy, in the second month it is likely the retinal detachment. So a patient of acute retinal necrosis on valacivir presents to you with sudden vision loss. It's an unexplained vision loss. It is not explained by the amount of retinitis. You think of optic neuropathy and please start the patient on IV methylprednisolone. So let me skip this part and go to the management algorithm directly. So clinical diagnosis of ARN is made, then you see whether the patient is immunocompetent or immunocompromised. In an immunocompetent patient, look at 2 factors: how much is the retina involved and how much is the severity of inflammation based on the anterior segment and the vitreous involvement. If it is less than 25% of retina involved with mild vitritis, there is no need of intravitreal treatment or oral steroids. You can start on oral valacivir 1 gram 3 times a day. If the amount of retinitis is more than 25%, there is moderate to severe vitritis. you have to start oral Valacibid 2 grams. It is not 1 gram, then 2 gram you have to start with. You have to supplement with intravitreal ganciclovir 2 times weekly, and then oral steroids need to be added. This Valacibid you need to continue for minimum 2 months following resolution of retinitis. In immunocompromised patient, irrespective of amount of retina involved, you have to start with 2 grams 3 times a day. Intravitreal ganciclovir need to be given, oral steroids need to be avoided. And it is not just 2 months you have to continue the therapy till CD4 count is more than 200 repeatedly. So this is an example, a non-reactive HIV patient. Now you can see that amount of retina involved is more than 25%. So we started with Valacibid 2 gram TID, we gave intravitreal ganciclovir along with oral steroids. But this patient, similar retinitis but is retropositive, so we'll avoid oral steroids, we'll give 2 gram 3 times a day.
You need to come.
Yeah, that was the last slide, sir. So I will skip the learning points. Thank you.
I never asked you to stop, actually.
I will go through the learning points.
Right. No. In ARN, in the clinic, this is very dangerous disease.
Yes.
We have followed, we have burned our hands very badly in this. If there is 1 or 2 lesions are there, and you are seeing in the evening, how do you suspect? Because this you live for 2 days, I am telling you, most of the audience, you will totally extensive.
There will be extensive
lesions
circumferential spread.
Very fast progressive disease, this one. And you may lose the eye in no time. Actually, you don't have much time to observe and say, I will reconfirm the diagnosis. Nothing like that will happen. So how do you suspect if 1 or 2 lesions are there and you need to suspect that this is ARN, nothing else?
So there will be peripheral retinitis first of all. There will be no retinal hemorrhages surrounding that. And along with those retinitis, you will see a vasculitis. That is arterial involvement will be there. That is classic of acute retinal necrosis.
Arterial rather than
arterial
venous
involvement. Yes.
Venous involvement.
Yes. So there will be always arterial involvement associated with that small retinitis lesion surrounding that area. But if it is extensive, you will see that arterial involvement extending till the posterior pole. That is a frank case. But early and central clearing can also be there. Sometimes it won't be there, but if it is there, it is
by
classic.
By that stage, I think it's more extensive.
Yes. By that stage, it is extensive.
The second is you nicely explained about how to suspect a virus or tox or anything like that. So I will not ask for that. But you have started on treatment and this patient responded. How you will ensure that this patient's eye is now saved for a long term?
Safe for long term, not in terms of retinal detachment, but in terms of recurrence, we can say. So, as I told you, the treatment need to be started, and then once the retinitis has completely resolved, minimum for 2 months you have to continue the treatment. And for 2 months you have to follow up the patient every 2 weeks after the retinitis has resolved. If there is no involvement of the other eye by 2 months, then after slowly you can taper. So you start with 2 gram TID, the maintenance dose is 1 gram BD. Then after 2 months you can do 1 gram OD, and in 2 to 3 weeks if there is no recurrence in the other eye, you can stop
regarding the oral treatment.
Oral treatment,
completely agree, and you have covered it. I am asking something else, is that prophylactic laser.
So prophylactic laser has a contraindication, sir. So reports are there.
In which cases it is indicated, which cases it is contraindicated?
So the risk or the incidence of retinal detachment is more when the amount of retinitis is more. When the amount of retinitis is more, there is more vitritis also. So laser is not possible in such cases where there is already a risk of retinal detachment. When the retinitis is less, vitritis is less, those patients we can do laser, but then there are less chances of retinal detachment in those patients.
The next question is when to do the lasers. See,
so you can,
when active inflammation is there, you are doing laser means you are burning your hands.
Yes.
But
once the retinitis is resolved, so what are the signs that patient had an acute retinal necrosis in the past? Patient might present to you in a healed state also. So in the periphery, you will see a sieve-like retina or a scalloped appearance. Yes. And you can differentiate that this is the involved retina and this is the uninvolved retina. So you can do a barrage laser at the margin of the involved and the uninvolved retina if you would like to do, and you feel like this patient has a high risk of retinal detachment. The sieve-like retina or the holes are much more and can cause retinal detachment. You can do a barrage laser at the margin of the involved and uninvolved retina.
And once RD happens, what will it?
So once retinal detachment happens, these patients are at very high risk of PVR. So a high buccal, a broad buccal, high buccal indent and a broad buccal is essential prior to vitrectomy in these patients, because once the PVR happens, there is also the risk of hypotony in these patients because of the contraction. A high buccal indent, a broad buccal and a 5000 centistroke silicone oil is preferable. Complete vitrectomy should be done. Vitreous base should be cleared to the extent possible in these patients, and long-term silicone oil is needed because they are at high risk of hypotony once you do the silicone oil removal.
Yeah, you should be prepared for keeping the oil long term. The belt buckle and these are a little bit less indicative. If you operate, you will see that the retina, a lot of tissues necrotic. And there is no tissue actually. There will be small lines.
Difficult to find the break also. There will be multiple
vessels will be there, but rest of the retina, there is no retina actually. How can you say this is smaller break or bigger break? The whole retina is necrotic, and the areas where ARN is severe, those cases no retina at all. So these cases you need to be prepared to keep the oil for very long term. So the best of the oils you should use and keep the patient also. And certain times you may keep on exchanging the oil rather than removing the oil.
Yes, sir.
Thank you, Megha.
Thank you, sir.